Today, you will learn about TeamSTEPPS, a communication framework. Assertive communication ensures voices are heard. 2 challenge rule, make sure concerns aren't brushed aside. CUS word stands for concern, uncomfortable, safety issue. C, I'm concerned. U, I'm uncomfortable. S, this is a safety issue. Debrief closes the loop so teams can learn and improve together.
Welcome to EM Pulse, bringing research and expert opinion to the bedside.
We're your hosts, Sarah Medeiros
and Julia Magaña.
This happened in our resuscitation room. It was a patient who was brought in after a pretty bad MVC. He was very sick. He needed a lot of interventions right away. Sounds like the room was really busy, chaotic, a lot of people in the room, and the decision was made quickly that the patient needed a mass transfusion. So we have a hemobank in our resus room where we can get blood for patients right away. So the trauma surgeon asked for the staff to start a mass transfusion out of the hemobank, and when the tech went to get the blood from the hemobank, they came back and said there was some glitch with the hemobank. They weren't able to get the blood. And apparently this was extremely frustrating for the trauma surgeon, and he cussed to the team and then began to insist that they get the blood from the hemobank whatever way they could, which would mean going, or I don't even think we could figure out how to make this happen. But if we even could, it would involve us going around safety procedures and tricking the machine some way. So when he asked for staff to do that, there was a CNL in the room, Rachel. She's a clinical nurse leader in our department, and she wasn't really active in the resuscitation. She said she was just kind of standing back and watching because she recognized there were kind of newer nurses in the room and she wanted to make sure everything was staying safe. And so she spoke up immediately and said, no, we can't do that. That's against our policy. That's not safe. It's against our protocol. And I guess that just kind of put the kibosh on it. The decision was made like, okay, it's true. We're not going to do that. We're going to do what we're supposed to do, which is go to the blood bank and get the blood. As soon as the resuscitation ended, again, there were still a lot of people in the room, and the trauma surgeon apparently immediately apologized to everyone in the room and thanked them for not doing what he had asked them to do. And when I heard about this, my first thought was, wow, I almost like this guy more than if none of this had even happened. Like the fact that he was able to recognize his mistake and apologize right away, and that's just a really hard thing to do. So I think he earned a lot of respect from everybody. It's also nice that the ER team was able to give him that understanding. Like, they accepted his apology.
Welcome back to EM Pulse. Today we have a special guest, Dr. Neelou Tabatabai. She is an assistant professor of emergency medicine at UC Davis and an enthusiastic educator, to say the least. Welcome, Neelou.
Thanks, Julia. I'm so excited to be here. This is my first time co-hosting, so Thank you for having me.
Neelou, on EM Pulse, we've actually discussed communication in the emergency department. Specifically in September 2021, we spoke about the TeamSTEPPS framework to improve communication in the ED. But there is always more to learn when it comes to communication in the emergency department.
Oh, I absolutely agree. I think communication is life-saving, especially in the emergency department where teamwork is so essential.
Yeah, it's one of those underappreciated kind of life-saving skills. And I think that we need to just keep diving in. So we brought back a TeamSTEPPS communication advocate, Leigh Clary. She is a bedside nurse and a TeamSTEPPS project lead. Leigh, welcome back to EM Pulse.
Thank you. Thanks for having me back.
Now, remind us briefly, what is TeamSTEPPS?
TeamSTEPPS is Team Strategies and Tools to Enhance Performance and Patient Safety. That's the acronym. It was developed by the Department of Defense and the Agency for Healthcare Research and Quality to address patient safety issues. I think it was in the late 90s when there started to be a lot of attention given to medical errors and the impact that they have on patients. And that's when the Department of Defense started working to develop a program to address that.
Sounds like it's a playbook for teamwork in healthcare.
Yeah, that's exactly right. It's a lot of strategies and tools that anyone who has not taken TeamSTEPPS is probably already using these to some degree. But this just gives us a framework where everyone's on the same page and has the same expectations about the way that we communicate safety concerns, the way that we help each other out, the way that we stay situationally aware of things that are going on.
Okay, Leigh, let's talk about the scenario we just heard. What were the first signs that this was becoming a conflict situation? Like, what do you think people saw that were like, caused their spidey sense to go off?
Well, I think it was seeing the surgeon, who's the leader in this situation, kind of lose his composure. And apparently when this happened, the patient was undergoing a thoracotomy, and the trauma surgeon was actively involved in that when he realized the blood was not going to be coming immediately from the hemobank. And it sounds like he said a cuss word, and I'm sure that that's when everyone realized we've got some conflict on our hands here.
So as I heard in the story, it sounds like there may have been some even earlier signs, if I may, that you had an inexperienced team and you had a very stressful situation. And it felt almost like this was a potential setup for something for conflict to arise, right? You have some really experienced people, you've got some inexperienced people, and you've got a stressful situation. Because you already said that you had a nurse lead that was standing around ready to go, right?
Yeah, I mean, I wouldn't say that I think that she was anticipating conflict, or I don't know that there's any reason that anyone would anticipate necessarily that there would be conflict. There's always the potential for it.
Because you work in the emergency department.
Yeah. It's high stress. There's a lot going on, and sometimes we're going to have different opinions about how to proceed with something. So,
does TeamSTEPPS have a term or a specific thing for that type of conflict that we can like identify it as, that conflict of the surgeon losing their composure?
Not specifically. We talk about the difference between informational conflict and interpersonal conflict. And we talk about the way that informational conflict can become interpersonal conflict, and informational isn't necessarily wrong. It can help us figure out how to proceed in the safest way. But when that's not resolved, then it can turn into interpersonal conflict, and that can really impact your team.
So would this count as interpersonal conflict then?
It's a good question. I think I would say no. I think it probably had a lot of potential to. And if the trauma surgeon had not had that self-awareness and stopped and made the apology, then I think it could definitely have turned into it, because then there would have been a lot of chatter around the unit. Hey, did you hear what happened? Did you hear how this guy acted? And the next time we saw him in the resus room, we would have all been on edge. So I think that TeamSTEPPS allowed us to keep this from turning into interpersonal conflict.
How did TeamSTEPPS training come into play in the moment?
Well, when I went and reviewed this case, there were so many different TeamSTEPPS tools that were used. Just Rachel, the clinical nurse leader's presence in the room right there was use of situation monitoring, which is where we're staying aware of everything that's happening at once, which can be hard to do in a situation like that because you can get hyper-focused on one thing. When Rachel told the trauma surgeon that we could not get the blood from the hemobank, that was an assertive statement. So that's a tool that we're taught to use to speak up when there's a safety issue. And then I think she even had to come back with what's known as the 2 challenge rule, which is, I think that she said that and then he kind of challenged her back. So she had to say it again. The 2 challenge rule is invoked when you don't feel like you were heard the first time. So we know we have to say something at least twice to make sure that we've been heard. And then at the end of the resuscitation, when the trauma surgeon made his apology and they all kind of discussed the case, that's a debrief. So a debrief happens at the end where you look back at what happened, talk about what went well and what could have been better. And then in the course of that debrief, I think they also recognized where the problem had come with the hemobank in the first place. So they were able to talk about how they could avoid that whole problem happening again in the future.
Can you give us an example of how you could use an assertive statement and an example of the 2-step challenge? Like, how can you use that tool?
What Rachel said is, it doesn't work like that. the machine won't let us just pull out blood without scanning. And then he said, we'll give him someone else's blood then. I don't care whose it is, just give him some blood. And then she came back with the 2 challenge rule of, no, we cannot do that. So it's really just being firm. When I'm teaching this content to especially new people, I emphasize a lot how this really comes down to confidence. You have to feel confident, and if you know that there's a patient safety concern, say it. And I also tell people, maybe you make that concern heard, and it turns out that everyone else doesn't agree. Maybe you weren't quite right. You were still right to bring it up.
When you're teaching people how to use that, do you have specific phrases or tools that you tell them to use as they're, getting the confidence to be able to say that, to call it out?
You could say that there's a third step in the assertive statement 2 challenge rule. The third step is cuss words. So we know in our department that anytime you hear, I am concerned, this is not safe, or I am uncomfortable, then everyone is expected to stop what they're doing and reconsider the situation. So those are our main 3 cuss words.
Not the surgeon's cuss words.
Different type of cuss words, yes.
Okay.
What do you think made it possible for the team members to push back safely? Do you think it's the training, the culture, the leadership?
Yes. I think it's all 3 of those things.
Yes. I love it.
And I'm really proud of it. When the nurses were telling me this story, Christina, who's one of our Clin 3s, she said, in absence of our TeamSTEPPS training, I can totally see someone finding a way to get the blood out of the hemobank and going around our safety procedures and doing that. And at first I was like, no way, no way. And I think it's just because now I'm so used to our culture of safety and standing up for what is right and what is safe that it sounded outrageous to me. But then I thought back to my younger years as a nurse, or maybe being in a different facility and, being intimidated by the trauma surgeon and feeling like I've just got to do what he says. But no, our culture teaches us differently.
How do you think the surgeon's apology was received? Do you feel it was genuine, surprising, uncomfortable?
I think that it was surprising, and I do think it was very genuine, because everyone that I've talked to that was in the room was really impressed with it and very thankful that he ended it that way. It left everyone feeling actually pretty good instead of terrible.
And you mentioned earlier you felt more respect for him.
Yeah, that's what I heard everybody say.
And the other tool that you mentioned is the debrief, and that sounds like the apology happened during that. Can you tell us how we can use that debrief tool? I'm sure we've all debriefed to some extent, but what is the TeamSTEPPS framework for doing a debrief?
Well, I'd say we have a couple of levels of debrief. So one, we have a kind of formal debrief. And so that's one where we all plan to come back together, usually a few minutes after the event. We all kind of go our separate ways after the event and then plan this out. Our charge nurses are always really good about finding resources to cover people so that we can all come back and talk about it. These are led by our peer support committee. They have a framework of questions they ask. They make sure that everyone in the room feels safe and comfortable. A lot of these debriefs that are set up in this way, a lot of them have an emotional component. So events with bad outcomes, events involving children. So those are our more formal ones. And we do talk about what went well, what could we have done better, and it helps everyone feel like we can move forward from a better space. I would like us to see doing more just sort of informal ones, which is, I think, what happened at the end of this particular event, which is where you just kind of get together and talk about it. Like, hey, I didn't understand why we did this. Can you explain to me why we did this instead of this? Or, oh, thank you so much for helping me with this. That was very helpful, and that reinforces that should be done the next time. So there's different ways to debrief. I really wish people could understand that it can be super informal and just come together and talk.
You're making me remember my shift last night, and I'm like, oh, shoot, I should have done a debrief after that code last night. Now I want to bring everybody back together and hit replay.
Yeah, you have to do it. You have to do it within a few minutes because you'll never get that team back together again.
Yeah, totally. And we walked out of there, and as it often does, the emergency department had blown up while we were in there for so long. So it was really hard to make space for that.
It can be hard. It can be hard.
And honestly, I just completely slipped my mind last night, but it's really is a valuable thing when you have that space and we all learn from it. The interesting thing is I probably had like 4 or 5 nurses come by and talk to me individually about it afterwards, which was great. And I'm always open to that, of course. But I probably could have even saved time.
Yeah. So those were debriefs, they were debriefs. They may have just been on an individual level, but it's much better than nothing.
Yeah.
But I do think when we have our debriefs where the whole team comes together, in addition to the benefit of identifying opportunities and reinforcing successes, I really do think that it helps us walk away having processed things a little bit better. And because some of these events, they can be pretty emotional and they can leave you feeling pretty heavy.
What lessons do you think the team took away from this experience?
I think the younger nurses were able to see the importance of being able to stand up to someone who seems to be higher in the hierarchy than you. They were able to see a real example of that, and they did approach Rachel and say that they were glad that she did that for them. I think people in the room were able to see the benefit of having humility and being able to admit when you did something wrong. Again, like I said, that caused people to actually have more respect.
There's strength and vulnerability there. I like that.
Vulnerability. Sure. And I think that people were able to practice giving someone grace and being able to move forward and not let it linger and turn into, long-term conflict.
So, Leigh, how do we prepare staff, especially new ones, to speak up in these kinds of moments?
So the TeamSTEPPS program, it's free and available for any entity to use. And we took the program and we really molded it to our department. So all of our new staff go through TeamSTEPPS training. And in that training, they learn all of the 12 tools and they practice the 12 tools. So I say that it's like being in the simulation lab. We are pretending like we are in the room and we are practicing how are we going to interact when these issues arise. So people actually practice this in a classroom setting.
Leigh, you're also a bedside nurse. So you're not just like teaching other people to do this, but you are in the trenches with us in these moments. When you're coming onto a shift, how do you prepare? I mean, all of these things, you've practiced them for a really long time, but how do you prepare to be your best self and to be able to use these tools when you're coming onto a shift?
Well, as the TeamSTEPPS project lead, I always have to remember that I'm setting an example and people are looking to me to know how to use these tools. And people do come and they ask me for advice on how to interact and how to use tools, especially when they're having a conflict or a problem. When I'm preparing for a shift, I don't know. I feel like it's just become sort of second nature to me now to use these tools. That doesn't mean in the moment I don't have to stop and maybe plant my feet on the ground and take a deep breath and decide how I'm going to use it. But it would be very difficult for me to let a safety issue pass by at this point.
Yeah, I think that's a really great tip. And it sounds like it's just the sheer muscle memory of doing this over and over again and thinking about it and you practicing that framework that makes it easy for you to integrate into each shift. I would also say some of the ways that I personally prepare for each shift to be able to be my best self is obviously trying to get good sleep beforehand. Oh, yes. Exercise, come fed, bring a water bottle. Take a moment as I'm driving into my shift and center myself and letting go of everything else, because it's hard when your body or your mind is clouded with other things to apply these resources in challenging moments. And so those are some of my ways to be able to come to the shift as my best self.
Definitely. And also recognizing that everyone else around you maybe has not done that or isn't even able to do that. So one of the TeamSTEPPS tools that I mentioned before, situation monitoring, one of the components of that is monitoring your team members' status. And so that can involve recognizing that your team member may be having a hard time. Something may be going on at home. They may be extra frustrated because of this thing that happened earlier in the shift. And just realizing that everyone is coming from a different place every day.
So, Leigh, is there anything else you'd like to share with us?
I think that the discussion about this event has been a lot about conflict, and I think it's important to note that conflict is not something that you want to avoid in your department. Conflict can be very productive. It can keep us safe. It can keep our patients safe. It's just that conflict needs to be productive. It's not personal. So I just think that's an important thing to note.
Okay, well, thanks, Leigh, for that summary. It seems like there are many potential discussions to be held on the topic of communication, so I think we're going to be calling you back, Leigh. Is that okay?
Please.
Thank you to our department for supporting people like Leigh so that we can all communicate better.
Thank you to OM Productions for helping us sound like clear communicators.
And thank you, Neelou, for joining us today.
Until next time, stay curious, stay inspired, and stay tuned.
The opinions expressed on this podcast are those of the hosts or guests and do not necessarily reflect the views of UC Davis Department of Emergency Medicine, UC Davis Health, or their parent organizations.